Thank you all so much for joining us. We will begin the session in just a moment. I would also like to advise that those participating that we are recording tonight's session. And I'll get started in the next 15 seconds. Just waiting for a couple of latecomers. Thank you all so much for joining us. Might get started now. Good evening, all. On behalf of Eastern Melbourne PHN, Northwestern Melbourne PHN, and Dementia Training Australia, I wish to welcome everyone to the Demystifying Dementia Session 2, Post-diagnostic care of dementia in general practice. My name is Nicole Stark, and I'm the Events and Education Coordinator at MFM. Before we begin, I would like to start with an acknowledgement of country. Eastern Melbourne PHN, Northwestern Melbourne PHN, and Dementia Training Australia acknowledges the Wurundjeri people and other people of the Kulin Nations on whose unceded lands our work in the community takes place. ENFN respectfully acknowledges their ancestors and elders past and present. In the spirit of reconciliation, Eastern Melbourne PHN acknowledges the traditional custodians of country throughout Australia and their cultural, environmental, and spiritual connections to land, sea, and community. We pay our respects to their elders past and present and extend respect to all Aboriginal and Torres Strait Islander people today. We recognise and value the knowledge and wisdom of people with lived experience, their supporters, and the practitioners who work with them, and celebrate their strength and resilience in facing the challenges associated with recovery. We acknowledge the important contribution that they make to the development and delivery of health and community services in our catchment. Just some quick housekeeping. All attendees will remain on mute throughout the presentation. Please type any questions for our speakers in the Q&A box at the bottom of the screen, and these will be answered at the end of the presentation. A little bit about PHNs. The Australian government established primary health networks to increase the efficiency of medical services, reduce fragmentation of care, and improve health outcomes for everyone, especially for those most vulnerable. Eastern Melbourne PHN and Northwestern Melbourne PHN achieves this goal by improving access to existing services, commissioning services to improve health outcomes by supporting GPs and others to innovate and further improve local healthcare. We aim to improve the health of our community by ensuring people receive the right care in the right place at the right time. We all thank you in joining us for this valuable RACGP accredited education activity. Dementia is a term used to describe a group of conditions characterized by gradual impairment of brain function, which may impact memory, speech, cognition, personality, behavior, and mobility. Dementia is a significant and growing health and aged care issue. It is the second leading cause of death in Australia, with more than 400 Australians living with the illness. This evidence-based program has been designed to improve both confidence in clinical ability and attitudes to dementia care. This session will describe a practical approach to support GPs in diagnosing and managing dementia. I'd like to start by introducing our fabulous speakers. Dr. Karen Savory is a Brisbane-based GP who works in clinical practice, residential aged care, and medical education. She is passionate about education and mentoring of GPs, particularly in the aged care and dementia. She works with Dementia Training Australia to increase GPs' confidence in the recognition and management of dementia. Dr. Marita Long is a speaker and lead GP educator with Dementia Training Australia. She graduated from University of Tasmania in 2007 and has extensive experience in general practice. Dr. Long specialises in developing innovative workshops to enhance GPs' capacity in recognising and managing dementia, with evaluations published in BMJ Open. Dr. Precious Maguire is an experienced GP with over 30 years of practice. She offers holistic, whole of life medical care, which includes shared maternity care and mental health expertise. Graduating from the University of Queensland in 1986, she is accredited with Eastern Health, Mercy Hospital for Women, and Royal Women's Hospitals. She also has an aged care practice and is a clinical editor for Health Pathways Melbourne. And on that note, I'll now pass the metaphorical mic to Marita. Thank you.
Great. Thanks for having us again. We're glad that, well, we hope that most of you did the first session back today. Otherwise, there should be a recording that you can access. And I was just listening to what you were saying, Nick, and I guess we're all here tonight to really make general practice future ready to be better equipped to care for people living with dementia. So I think we're going to start our slideshow. And if we can move on to the next slide, and that's just to acknowledge that although it's Karen and I standing here tonight, there's been lots of people who have contributed over the years to the development of this workshop. And if we move on to the next slide, that's going to be a very learning outcomes. So review the various frameworks that are available to assist us in making a diagnosis of dementia, which we know we all find tricky. How to deliver the gift of the diagnosis, and we'll talk a bit about why we use the word gift there, and also how we might initiate some post-diagnostic care using our stages and domains framework. So if we go on to the next slide, this is just some beginning with the end in mind messages, which is really just saying that GPs are probably in most cases able to diagnose and care for people living with dementia. So we can move on to the next slide. Thanks, Jenny. This is going to be a little bit of a recap on our frameworks just before we start getting into the meat of tonight's session. So this is the domains of dementia. This is one of our frameworks which should help guide your understanding of dementia and also how you might construct a history when you're asking people about the kind of impact that their symptoms might be having. And so the first domain is the cognitive domain. So that's around thinking, reasoning, judgment. It's where we see most people report memory issues. And then functional decline. So that's around doing things. The psychiatric symptoms waxing in and out of the course of dementia potentially, but also people who can present with, depression or anxiety in those early stages. And behaviour changes, these again are things that we can see early on in the course of dementia where someone might become apathetic or withdrawn, or we might find later on where they develop some behaviours that can be a little bit more difficult to understand and indeed care for. And then, of course, not forgetting physical decline. Again, there's often some physical decline in those early stages, but we're really referring to the marked decline as their sort of global deterioration. So that's our domains of dementia. And then we've got our stages, which is the second framework. And remembering that the stages aren't as clear-cut as our lovely kidney guidelines or a cancer diagnosis where we can really mark out a clear stage. These are very nuanced, and it's really just to guide what the natural history might be, so to be able to tell people about what to expect, what might be coming up, and also to guide our management. So if we move on to the next slide, I'll talk a little bit more about the stages on that next slide, because this is probably one of the things that we really hear back from GPs, and I certainly find this helpful in my practice in terms of putting the stages and domains together. So I've got a little bit of a time trajectory there. We see in stage 1, this is where we'd like to make the diagnosis, where people are still at home. So we're seeing a decline in cognition and function, and that's a gradual and progressive decline. And then if we move along to the psychiatric symptoms, we've got that as a curvy line that's moving in and out, because really those symptoms can occur anywhere throughout the course of the illness. And then if we look at the bottom slide, those behavior changes, it can be a little bit variable in those early stages, but probably really peak in that transition from stage 2 to 3. This is often in that time currently stage 2 to 3, that transition point where the slide looks very messy, is often where we are seeing people present into general practice, because they've sort of been able to manage up until this point in time, until everything kind of collides all at once. And then we've got that sort of physical decline. So this is a really useful slide to sort of gently give people some of that anticipatory advice when people want to know, what might happen. So again, stage 1's where we really want to make our diagnosis. So we're going to move on to the next slide, which Karen's going to really step us through our other framework, which is the inclusion and exclusion criteria.
So yes, so again, just a recap from last time where we did spend a little bit more time going through our domains and stages. This is our inclusion criteria. So this has been distilled down from the DSM-5 to make it a very practical way of assessing somebody who's sitting in front of you. So to make a diagnosis, particularly of Alzheimer's or vascular dementia, we want to see all 4 things present. So it has to be gradual onset. You can't have had normal memory a week ago and suddenly you don't now. So it's got to be far more gradual in onset. It's got to be getting worse over time. So if we look back that 6 or 12 months, we can really see those significant changes occurring. And alongside of that, as we saw in that nice graph, is we really see that failure of function as well. So not only does your memory have to be gradually getting worse, we also want to see some of those things that you were able to do 6 or 12 months ago that suddenly are also showing difficulties. So the person that's really struggling now to do their banking or to follow a recipe, getting lost more easily. So some of those things that they might have always done without much difficulty that are becoming more difficult. And then that final one is some cortical dysfunction. So really looking for dysphasia, so some of the verbal fluency, word finding difficulties, some of that very circular speech, the thing that does. So really having some difficulty with that verbal fluency. We look for, as we're probably very aware from some of our MMSEs, the difficulty in naming objects, our agnosias, and then dyspraxia is difficulty in sort of knowing what to do with the objects. So people start having a lot more difficulty with things like their remote controls or their phones. And then again, in some of our cognitive assessment tools, we're looking for constructional dyspraxias like the intersecting pentagons or the clock face that we actually do. So we want to see all 4 of those there to be making a diagnosis with the person sitting in front of us. But we also need to make sure they don't have any of the exclusion criteria. So if we can move on to the next slide. So to make a diagnosis with the person sitting in front of us, we need to make sure that they don't have delirium. Because if they do have delirium, we can't make a diagnosis in the presence of delirium, although, as we spoke about last time, we really want to watch people who are developing delirium and put recalls in to keep reassessing their cognition, because it's highly likely that we may actually unmask either dementia or somebody that is at risk of dementia down the track. But in the presence of delirium, we can't make that diagnosis at that time. We can't make the diagnosis in the presence of other things that might be impairing cognition. So, and that's where some of our examinations and investigations come in. So looking at some of the typical things like hypothyroidism, calcium, some medication that we give people, alcohol intoxication. So lots of things that kind of might impair cognition that we're going to exclude. And then in the presence of good going psychiatric illness. So if we've got any of those things there, we want to treat them as best we can and come back and reassess cognition, because it's possible they may have a diagnosis of dementia. We just can't make it while they have untreated things going on that are impairing cognition.
Great. So if we move on to the next slide, we can see that for most people with Alzheimer's, dementia or vascular dementia, most of these people are probably diagnosed over the age of 65. But I think it's really important that we start to think of dementia like a chronic disease and understand that the pathology is starting probably 20 to 30 years before that diagnosis. So what we want to be able to do, as well as someone who has dementia, but before that time, we really want to recognise that one of our aims in general practice, knowing that prevention is better than cure, and in the case of dementia, at this point in time, there is no cure. Prevention is really important, and it's never too early or never too late to be thinking about brain health. So if we move on to the next slide, we have been incredibly fortunate that there's been a lot of researchers who have been working in this space for many years. And in 2020, where many of us were sitting in lockdowns all around Australia, the Lancet brought out a great report. It was an updated report that now recognises 12 modifiable risk factors for people with Alzheimer's disease. And they break these up into early life, so that's considered to be under the age of 45, midlife, 45 to 65, or late life, over 65. Now, these factors are, I guess, put in these age brackets because that's really where they have found the evidence for them. But if you look at something like diabetes, we're not going to not worry about that until someone gets to 65. So these are things we should be thinking out throughout the life course. So the 12 modifiable risk factors we've got is education, and that really refers to achieving grade 12 standard of education, which most people in Australia are fortunate enough to achieve. Not everyone, but most people. That doesn't mean that if you didn't get to year 11 or 12, we don't worry about you. Of course, we have the understanding that lifelong education is really important. Midlife, we're looking at things that we're probably all familiar talking to our patients about: high blood pressure, obesity, and alcohol. The things that we're probably not so familiar talking about, not thinking about in terms of something like dementia, is hearing loss, and hearing loss is incredibly important. So, we know that people tend not to want to ever do anything about hearing loss. They think, oh no, I'll be okay. But I think we need to recognize in midlife, it is really important to address it. So if someone comes through that, moderate sensory neural hearing loss, and they say, oh no, I'm okay, it doesn't affect my impact, you can talk to them about this being a risk factor, and perhaps that might encourage them to think about correcting that. Traumatic brain injury, we're hearing a lot in the news about, CTE, so the sports-related repetitive concussions, but we need to be thinking more broadly than that as well. So people who fall off motorbikes, motor vehicle accidents, domestic violence where people have been exposed to repetitive head trauma, is very important to be thinking about that. And then if we move on to late life, we've got ones that we're really familiar with. We deal with diabetes most days of our lives. Probably most of us are dealing with people who are depressed most days of our general practice life. Social isolation, smoking, rarely would a day go by where we're not talking about smoking cessation, and physical activity. Air pollution, again, is probably one of those ones that we're not talking about in our consulting room, but we are very lucky that we do have a lot of GPs who are very active in sort of that environmental and climate change space. Sleep and diet are down the bottom there in grey. They're not included in the Lancet Commission report yet, but they are still considered significant risk factors. Sleep is becoming more, we're coming to understand more and more the importance of that. And in terms of diet, it's really looking at what we go to for most things, so Mediterranean diet. So a lot of the risk factors are going to be really similar for a lot of other conditions: cancer prevention, cardiovascular and stroke prevention. So now we're just putting it into a new lens where we're thinking about brain health. And just on the right-hand side there, I've just got population and individuals. So I think it's really important when we're talking to people, we talk about the fact that it's not just up to us as GPs and our patients in front of us. Government should also be looking at this from a population base. And when we're talking to individuals, we don't really want to put that heavy blame onto people. So I prefer to use lifestyle factors, not lifestyle choices, because for a lot of people, there can be a lot of structural barriers to making the best choice. Now, just quickly, the obesity and physical activity are bolded there. And that's because in a country like Australia, a developed country, they are probably two of the most important risk factors to be looking at and talking to people about in terms of dementia risk reduction. So if we go into the next slide, what we want this commission report, I guess, is to highlight that if you do find any of your patients who are at risk of dementia through having any of these risk factors, that you look at offering people a brain health check. Now, we've become familiar with the heart health check. This is a brain health check. And when would you do that? Well, it's really any time you can do it. We know that the pathology for dementia is starting 20 to 30 years before diagnosis. So midlife is a really crucial time to start targeting those. It's an opportunity where you can use an evidence-based tool, which we'll talk about in a minute, to establish people's personal risk factors and how you might want to work with the person through motivational interviewing or shared decision making. And I think we have lost the slideshow, have we? Great. So if we go on to the next slide, that's just going to be about when can we do one. There is no brain health check item number yet, but you could certainly incorporate it into your over 30-year-old heart health check. 45 to 49 year health assessment. It's a great time-based opportunity where you can tack that on to what you're doing already for your 45 to 49. If someone's at high risk of diabetes, again, you can sort of tack on this brain health. There's not many more things to factor in. You're over 75-year-olds who are at higher risk of dementia. You can do that when you do their annual health assessment. And also we can do annual health assessments for our ATSI populations who do develop dementia at a younger age and at significantly higher rates. Anyone in a residential aged care facility is going to be at higher risk. And also anyone with an intellectual disability can have an annual health assessment, so could have a brain health check, and particularly thinking about our adult patients with Down syndrome. So if we can move on to the next slide. This is the CogD Risk. So this is a tool that you can use if you do identify anyone at risk and to look at how you can develop their risk profile, which will come out with a number. If they're over 40, it'll come out with a number from 0 to 36.25. The higher the number, the higher the risk. It's not quite as developed as a cardiovascular risk, but the take-home message, if your patient does this CogD risk and comes back with a number, anything above 0 is high risk, essentially. So you want to be addressing what those factors are. You get a lovely report as well as a numerical score that refers to the risk of developing dementia at age 65. So if someone does this at their 45 to 49 year check, it's not their risk today. It's their risk if they don't address any of their modifiable risk factors at age 65. But it's a beautiful little printed out report that can be a really good springboard for discussing brain health with patients and how you're going to move on to modify or reduce that risk. And most of the patients that I've been doing the CogD risk really enjoy the opportunity to work with it and see what things they can do. Although I would have to say that, like a lot of preventative health, probably the people most willing to engage are probably at the lowest risk. But it's a good starting point. If you get familiar with using it with your patients, you can sort of then be able to do something with the patients who it might be a little bit harder or a little bit more challenging to engage with them. So I would suggest everyone watching tonight, go home and do the CogD risk yourself to see what your own risk profile is. So if we move on to the next slide, thanks. I'm going to hand you back to Karen now. And we're going to go back to Anna, who we met in our last webinar.
So just a reminder, and for those that may not have been there, Anna was a delightful lady who'd come for a flu shot. She'd attended with her daughter, which was unusual, and her daughter particularly had some concerns. The doctor had noticed that she was a bit late getting her flu shot, was a bit late with some of her tablets, and so had arranged to take a bit more history from her daughter and to get his nurse to do some assessments for him. She didn't have much going on in her past medical history and really wasn't on very much from a medication-wise that might make us think she's taking something that might impair her cognition. So we might just go to the next slide. So when the the doctor went through, Dr. George, and examined her. Examination was pretty normal. All of her blood tests and a CT brain, so really looking for those exclusion criteria. That was all negative and normal. She did score 23 on her MMSE, and she certainly had evidence of dysphasia and agnosia during that assessment. And a geriatric depression score had been done, and that was also normal. So if we just go on to the next slide. So when we're thinking about our inclusion criteria, and you'll have to take our word for it if you weren't here, or go back and watch the video, but certainly she had demonstration of sort of poor memory that was getting gradually worse. She was certainly having some failure of function compared to where she'd been 6 or 12 months ago. She was struggling with the garden. She was leaving her stove on. She was really withdrawing from some of her social contacts. And she definitely had evidence of cortical dysfunction with that dysphasia, agnosia, and dyspraxia. And I might just stop for a moment there, Marita, because I've just noticed in the chat someone has asked about, I'm assuming that's mild cognitive impairment versus early dementia. And probably our main sort of take-home message is that number 3, that failure of function is a really key distinguishing thing that you'll notice, and also the cortical dysfunction. So you certainly may see some mild cognitive impairment where people's memories are poorer than their peers, but actually they're still managed to do everything that they would normally do. Obviously they are at risk, and about 10 or 15% of them will progress. But that failure of function and cortical dysfunction are kind of the critical things to really look for. So back to Anna. Anna met our 4 inclusion criteria. If we go into the next slide, through the investigations and the examination that we did, she didn't have any of the exclusion criteria. So there was no evidence of delirium. We couldn't find any other organic causes for her cognitive impairment, and there was no evidence of any psychiatric illness. So if we just go on to the next slide, I just want you to have a think about, particularly if you've seen the last one as well, how confident are you that Anna has dementia? Are you very confident? Are you somewhat confident? Or are you still not really sure? But certainly when we're looking at that framework that we've given you, we are quite confident that Anna has dementia, Alzheimer's type dementia. So we might move on to the next slide. I'll pass this back to you, Marita.
Okay, so now we're going to have a little look at a video of offering the gift of a diagnosis. And Karen, why do we call it a gift? Because it's not probably a gift I'd want to get.
It's certainly not a gift in that sense of the word, but actually the uncertainty that goes along with many people in that early phases before diagnosis, actually having some certainty and knowing what's going on, being able to think about future planning or the things that you might want to do or the things that we need to put you in place, it does become a gift of sorts, as opposed to in that messy time of that graph when you've had a fall and ended up in hospital and suddenly your whole world is tipped upside down. We want to be able to offer that gift or that certainty a little bit earlier if we can.
Yeah, perfect. So we're going to watch a video. It doesn't go for all that long, so you've got to put your thinking caps on, and we want you to have a think about what George did well in terms of delivering the gift of a diagnosis, what he could have or you might have done differently, and yeah, if there's anything that you think, oh, I would never have done that, or I would probably have done that, please feel free to pop it in the chat box. Otherwise, I'm going to have to make Karen tell me what she thinks.
So Anna, I've had a good look at all of your results, and I'm pleased to say the blood tests were all completely normal and the brain scan showed no sign of a brain tumour.
Okay, good.
But what that means is that the likely diagnosis for the cause of the changes that have occurred for you over the last 6 to 12 months is a form of dementia.
So like That's like Alzheimer's.
Like Alzheimer's. I guess I'm just interested to know in this situation, what do you already know about dementia?
Well, not very much, I must admit. I've never really thought about it. I guess it's one of those things you tend to put
Kind
on
of
too
get
hard basket
back
or
to the
something. So I don't know a lot, really.
slide.
So perhaps if you could explain it to me.
I certainly can explain it to you.
Can
And
we
also
pop that back on the slideshow?
Sorry, just say that again.
Sorry, can we just pop it back to the slideshow now?
Yeah.
Yeah. So it looks like I'm going to have to make Karen do a little bit of work here to tell us what you think Dr. George did well and maybe what you might have done or you think he could have done differently.
I mean, I'm assuming that, he set up that consultation where he's really looking at giving her the results and the diagnosis fairly promptly. So he's not beating about the bush. He's not making them sort of wait for that. He's mentioned the word dementia in that space. And that's, it is kind to our patients if we're not sort of spending 20 minutes beating around the bush trying to not say what we think might be going on. So I think in that sense he was very clear. From Anna's side of things, she had been worried about having a brain tumor, which is why he'd put that there. Otherwise, I may not have done it in that way. It was kind of the good news and the not so good news. But I thought he was very respectful and really gave them a chance by pausing to see what their next questions or what they came back out with, rather than just launching into a whole heap of information.
Yeah, and I think he really did, strongly focus in there on Anna, so keeping her sort of central to that process. So the consult obviously went on a little bit longer, but I guess we were just wanting to highlight the importance of giving that diagnosis and using the word dementia, not sort of beating around the bush that you might have a little bit of cognitive impairment or your memory's not so good anymore. Really, the person needs to have that diagnosis with clarity. We had someone we spoke to on our podcast who was told that she was in the grey zone when she had a diagnosis of dementia, and she thought the grey zone was some sort of technical term and was Googling what is the grey zone of dementia. So she went away quite confused, not being sure what her actual diagnosis was. So if we move on to the next slide, because now we've made a diagnosis, one of the important things about offering this gift of a diagnosis is that you can actually start initiating some post-diagnostic care. And that's certainly a lot of the feedback that people are given or give us when they're given the diagnosis is it's like, well, you've got this diagnosis, get your will in order, go and have a nice holiday while you can. And, this is not a great diagnosis.
And we'll
so
wait for the memory clinic in 6 months' time to tell you what to do.
Yeah, and also, giving people hope, because it is a difficult diagnosis where there's a lot of stigma, there's a lot of fear. People fear that they're going to be, the house is going to be sold, they're not going to be able to drive, their finances are going to be taken over, they're not going to be able to make any more decisions anymore. So it really is trying to set up that positive pathway for them. So if we go into the next slide, sorry, the next one. Yeah, so we're coming back to our stages. And so mainly this is to look at how these stages are going to help guide our management. And so Anna's had a diagnosis made in stage 1. She's still living at home. She does have a little bit of support. Her daughter does drop in, and there are a few issues, with her leaving the stove on and not really doing the gardening anymore, but she's still at home and able to stay at home. And what we want to do is keep her home as long as possible. So our goal of care is to maintain independence, dignity through independence and safety. So stage 2 is where we're seeing those escalating care needs. And often this is where people are transitioning into needing 24-hour care, which is usually in a residential aged care facilities. There's not very many families that are set up well enough to be able to offer that support at home. There's the odd family you come across who actually are incredibly well resourced with lots of family members. And that's really about maintaining dignity through safety, because we start to see there's a little bit of risk sometimes there. And then stage 3, where we're really seeing that global deterioration, where mobility, continence are becoming a real issue. This is really about maintaining dignity through comfort. And most people with dementia will have this end of life care set up in a residential aged care facility. So if we pop onto the next slide, when we're thinking about our stages, we're overlaying that with our the domains of dementia. So we're thinking about how someone in stage 1, how their cognition function, their psychiatric illnesses, their behaviours, or their physical sense is being impacted. And that's how we're going to kind of set up the post-diagnostic pathway. So if we move on to the next slide, this is really how we're looking at a rehabilitative approach, or a re-enablement, as strengthening for the person and their sort of natural resources. So how we can optimize the person at home in terms of cognition, and how we can help those who are caring for the person. So we've got the problems listed there. So some memory loss or repetitive questioning, agnosia, that difficulty finding words, and maybe some difficulty with planning. So how can we sort of slow this down and help Anna's cognition be as robust as possible? So one of the first things we might be looking at is some medications, either to de-prescribe or review, or we might be adding in some medications. And then really it's about optimizing things like other comorbidities, cardiovascular risk, all those other things we talked about in terms of the 12 modifiable risk factors. Education, really important that Anna and Sophie both get some detailed education about what this diagnosis means and how it may play out. Of course, we do want to make sure that Anna gets her legal affairs and advanced care planning. Hopefully she might already have one done. But we sort of want to, you do have to do that a little bit gently and over time. And then you're going to look at who else can help us. So it might be that we can get an occupational therapist in, or we can get a physiotherapist in, or we can get some speech if we've got communication skills as a big issue. And it's all very well for us to tell you to do all these things, but there's not just like we're struggling and we're learning and becoming aware of dementia and what that means, so are all our allied health professionals. So there's not a huge amount of people who are upskilled and trained in this area. So sometimes it is about seeing what's out there in your area, but also if you're going to refer someone, perhaps giving them some detailed instruction about what you're hoping they can achieve. So if we move on to the next slide, which is really going to help us just think about some medications. So I'd probably put the de-prescribing first, but we're going to come to that slide in a minute. But we do have some medications. We have the cholinesterase inhibitors, which have been around for quite a long time. They do offer a modest benefit, particularly for cognition, so might slow things down for a little bit. It might actually keep someone at home for longer, and it can help sometimes with apathy and behaviours. They're pretty well tolerated overall. You do have to be aware of a few side effects. We usually suggest starting low, going slow, like most things with older people. And there are some PBS criteria there. So to initiate these, it does need to be in conjunction with a specialist. It doesn't mean someone has to see a specialist. It means you need to be able to ring a specialist to say, I've got this patient, Anna, she's 75, she meets these inclusion criteria, she doesn't have any of the exclusion criteria. I feel confident that she has dementia, most likely Alzheimer's, and I'd really like to try her on this medication. And most people will, if you've got that relationship, will be able to support you in that initial prescription. So if we go into the next slide, we also have the NMDA receptor antagonist, that's known as Momentine. There is only one of those on the market. That's got some stricter guidelines there in terms of what the MMSE needs to be. Again, there are some modest benefits that might help the carer. It might, in terms of the care requirements, it may delay going into a nursing home, but probably more limited benefit in cognition. There is some benefit that's coming through for these in using them in nursing homes for some behaviours, and they can be used together, but one would need to be on a private script. If we move on to the next slide, this is really where we're thinking about what other medications is the person person on, and is there any way that we can reduce that anticholinergic load? And that's particularly important if we're going to be using a cholinesterase inhibitor, because it kind of is counterintuitive to have a high anticholinergic load and then using a cholinesterase inhibitor. And there's so many drugs on this, and of course it's all about the load. So if they're on a lot of these other medications, and if you think about patients who might be throwing in a bit of Stemetal here and there, they might be on some anti-inflammatories, they might be on something for their irritable bladder, they might be having a benzo at night to help sleep, or they might be on some Targin for pain. Think about how many medications, and are there any here that we can look to reduce? And if we just move on to the next slide, there are some tools available that can help. This is one from the UK called the Stop Start Toolkit. There's also some great resources. I think it's on the PHN in Tassie actually, which has a whole deprescribing and how to do it, particularly for the anticholinergic load. But Dr. Precious might be able to tell us a little bit more about that if there's anything on your health pathways as well. And if we go on to the next slide, I'm going to hand you over to Karen. I'm going to have a rest from talking, and she's going to talk to you about how we might do this again for function for someone in stage 1.
So again, yeah, just thinking about that stage 1, somebody's still at home. The problem list, this was Anna's specific problems. Obviously, individuals may have different ones, but she was having difficulty with cooking and missing pills and looking at some of those potential safety side of things. So again, we can look at different ways that we can enable people to keep doing what they're doing. So if she's able to still do a little bit of cooking, how can we help her do that rather than just fully replace it with a meal service? Is there ways we can actually help her, or is she at that stage where she needs something like Meals on Wheels because she's just not managing anymore? Are there tips and tricks we can use to be able to have the stove turn off after a certain period of time, or do we need to be turning it off altogether? Certainly some of the reminder systems now are quite useful. I've got a young patient that's got alarms set that reminds him to drink and to eat lunch, because otherwise he just forgets and ends up being very dehydrated by the end of the day. Certainly using some of the labeling and boards with what the day is and what's happening today, any of those things that might help with orientation are useful as well. That carer education again is critical. So it's certainly something that either can be done by yourself, but Dementia Australia has a heap of resources for carers as well, both written resources but also support groups that are really useful to be able to again share ideas with other people who are going through similar things. We certainly want to be able to keep people socially connected, because we know that that's really important. And again, whether that's able to be done via the community or via your carer. And again, we've got lots of allied health who can help us if we need it. Probably the one thing that we get asked a lot is around driving. And so we've got a couple of tips around that, although again, there's no real definite one test that we can do that says yay or nay. But we might just go on to the next slide. The thing with driving is a diagnosis of dementia does not mean you automatically need to lose your license, but it does mean that your driving days are likely to be numbered. So you really want to have that conversation early, not the first visit, but certainly in those early sort of visits. And at very least, they're going to need to have that box tick that says, yes, they have a medical condition on their driver's license certificate. So if we just go on to the next slide. So some of the things that we can do in practice, we know that actually the best correlator for future accidents is people who've already had an accident or near misses. So being able to find out in your history about near misses and accidents, that's certainly should come into it. Equally, if your family members are concerned and not wanting to get into the car with the person, then that probably is an indicator we need to look a little bit further about their safety. The MMSE, though, unfortunately is not particularly good at all in helping us predict how someone might be when they're driving. MOCA is probably a little bit better, but some of the things that are used in Canada and the US, and I'm certainly starting to use it more as well in my own practice, is things like the Trailmaking tests. If you haven't seen them, Google them. You can just print the PDF and download it, and we'll show you what that is in a sec. But that's probably the closest thing where people have got to remember a task and then switch between the tasks, so as well as that bit of visuospatial sort of awareness. So it's probably as close as we can get to really seeing if somebody's able to do those things, because in a car it's not just about driving. You've also got to be watching the people around you, looking for people cutting in and out, pedestrians. There's lots going on when you're driving. The clock drawing tests and the intersecting pentagons, again, give us a bit of an idea. If you're really struggling with those, then we're probably really wanting to think about looking at OT assessments. So we just go on to the next slide. So this is the Trailmaking A. This is the easier one. And this is the doctor's sample. So you start on one. For those that haven't seen it, start on one and just follow it. So you ask them to start on one and follow it in sequence. So 1, 2, 3, 4, 5, all the way through on the full A4 page until they get to the end. If they can do that in less than 2 minutes and not make any errors, they're probably okay in their driving. If they're making more than 1 or 2 errors and taking more than 2 minutes, they're probably unclear as to whether they're safe. I prefer the Trailmaking B, which is actually a bit harder. So if we just go on to the next slide. So with this one, they have to remember the task, but also switch between numbers and letters. So 1A, 2B, 3C, all the way through to M, I think. So again, a full A4 page. So again, a much better indicator of how they're managing to think about more than one thing at once. And again, if you're doing that in under 2 minutes and you're not making any errors, you're probably okay. Taking 2 to 3 minutes, making 1 or 2 errors, probably you need an OT assessment. And if you're taking more than 3 minutes and making more than 3 errors, you're probably unlikely to pass an OT assessment. So we really need to think about whether it's worth doing in the first place. So we just go on to the next slide. OT assessment is something that is valuable. It is often, the complaint is often that it's expensive, which it is, but as part of that expense, you get a comprehensive look at someone before they get in the car, somebody that drives with them to actually see what they're actually like on the road, and then a report that you get at the end. And that becomes part of the cost of having a car on the road, same as petrol, rego, insurance, all of the rest of it that just needs to be done. I've got a young guy who's only 52 and we've been doing them every 6 months. He passed the first 2. We knew he wasn't going to pass the third one, so we didn't send him back again. But the first ones were that sort of rehabilitation opportunity. There was little things that they picked up on that he could improve while he was still able to. So that was really useful. And certainly it is something that, it is that tricky balance where we're not only advocating for our patients, but we have to think about their own safety, but also community safety as well. There's a question there about some of the coordination tests. So again, they may be useful. Some people will use the sit to stand tests, and obviously we're looking at the other things that come into that physical kind of assessment as well. So, what's their visual acuity like? What's their gait and grip strength, and other things that you might be doing as part of a typical driving license assessment. But we've got that extra overlay of cognitively, are they able to, do they have the judgment and the ability to manage the task of driving, which is quite a complex task. So yes, you can do some of those physical ones, but certainly worth considering, some of the cognitive tasks as well. So if we move on to the next slide, I might pass that back to you, Marita.
Having a look at people's cars or asking them, or the informant or the collaborative historian about their car is really important. You get some really interesting responses as well as to what sort of condition their car's in. And also, a lot of older people do have older cars that are quite unsafe as well. So really important to be able to ask about that. But it's always the vexed question, isn't it, Karen, about driving and dementia?
Yeah.
So psychiatric domain. So we talked earlier about people presenting potentially with a concomitant depression or anxiety, and certainly in those early stages where people are starting to wonder what's going on, where things aren't making sense to them, where they are forgetting a lot, or not able to keep up with people how they were, starting to sort of socially isolate because it becomes difficult to engage with a lot of people. Really important to think about, is there any sort of comorbid condition there? And remember, we said we can't diagnose if they are, so treating those really important, but that can come in and out at any point in time. Very important for people caring. We'll talk a bit about this later. Also to think about their mental health. We can use mental health care plans to help with a concomitant psychiatric condition. We know that more than 50% of patients with dementia will at some point in time develop hallucinations or delusions. And again, if you can forecast that to people, that might be something that will happen through the course of the illness. Then when it does happen, it doesn't become so frightening, because they've actually had that warning that might happen, particularly for the people caring for that person. So engagement, really important. Keeping people as socially engaged as possible. So there's a strong movement now around social prescribing, and there's all sorts of we sort of, because we're in this space, we get approached a lot about different research projects, and there's lots of people doing lots of research in terms of looking at ways of plugging people living with dementia and their carers into social activity that offers both some benefits, so some sort of peer support, some networking, and that social engagement. I think one of the really important things, and when you make a diagnosis, that you do alert people to the fact that someone with a dementia has low cognitive reserve, like we talked about in terms of delirium. So they are a little bit more prone to delirium. So being aware of some of those signs that can happen early, so that gets treated as early as possible. And one of the guys in our team, along with his health pathway, if we move on to the next slide, developed a dementia action plan. So just like you would have an asthma action plan or a COPD action plan or a diabetic sick day plan, this is a really useful tool to talk through the person with dementia and their carer, something that can be on the fridge, that they can be looking out for. So if someone does all of a sudden become a little bit more confused, or not as attentive, or a little bit more withdrawn, or a little bit more agitated, this could be a sign that something is going on. And so we try to have a policy where at our workplace, where young babies, but also old people, if they're unwell, they really do need to be seen, or at least triaged by our nurse on that day, because we know what a delirium can mean, particularly for someone living with dementia. And the last place we want them to end up, if it can be at all avoided, is hospital. So the delirium action plan is a ripper. So if we go on to the next slide, thanks. And then I'm going to hand you back to Karen now to talk about behaviours.
So the behaviours that we're looking at in stage 1 particularly often are around those agitation, frustration, or becoming a bit more withdrawal, or some of the apathy that we see in early dementia. So again, looking at ways we can try and engage people. And often we're really looking at things that they enjoy. So how can we engage them in things that they enjoy doing? So for Anna, who enjoyed gardening, it may actually be that we get somebody to help her with their garden, where she can do a little bit and still be able to enjoy being able to do some of that. It may be that we are able to utilise allied health, again, depending on your area, to assist with that, or through some of the My Aged Care, or if they're under 65, perhaps NDIS, looking at, again, what can we get? Community support. Can we get somebody that can take them shopping once a week, or get out to a art group or men's shed, or whatever it is that people are actually gives them pleasure and enjoys. And again, some of the day respite can be useful for that as well. So we're really trying to work out how we can really give the person the most the best quality of life, the most enjoyable time in this phase, when we're thinking about those different changes in their behaviours. We know that as people move into stage 2 and stage 3, we see some very different behaviours, and obviously the treatment of those is quite different. But in stage 1, most of the things that we see, it's really around trying to support what they're doing, and again looking at that dignity, as we said, by doing enjoyable activities and keeping them at home for as long as we can. And again, that education comes into that as well, as we've said a couple of times, particularly for our carers, in just working out what is kind of normal or what to expect, and what things that they can do when they're noticing.
Yeah. And I really like the way you said to get someone to come in and help Anna with the garden, not to get a gardener come in and do the garden because she's not doing it so well anymore. And I think, we all tend to want to, fix things and make things better for people. So if someone's struggling with their cooking, we'll get, meals, let's buy meals in, rather than bringing someone in who can perhaps keep that person cooking for longer and de-skilling. It's about sort of maintaining skills, isn't it? And I think that's a really different focus. And I think working with the sort of multidisciplinary team that we come across with our teaching has really changed the way that we think about that. So not just having, oh, remember there's Meals on Wheels, or there's, community service to do all these things. No, let's see if we can help the person keep doing these things for as long as possible, rather than kind of de-skilling them. So that was a really, really important point. Sorry to jump in there.
No, that's fine. So if we move on to the next slide, if you are having difficulties in managing some of those things, then Dementia Support Australia does have plenty of support for both carers and doctors. So that 24 helpline is actually for anybody, and the number is there, but they also have lots of resources. There's a GP line that you can call as well, specifically for advice around more medication, and it's a really good useful resource for both our carers as well as for you as well. So Dementia Support Australia certainly does look at some of that. How do we manage some of those changes in behaviour that we might actually see? Whereas Dementia Australia, slightly different, is more specific for carers, so much more fact sheets and support groups. So two slightly different focuses, but very similar names. Go
Then
on
you add
to
in Dementia Training Australia, and everyone gets very confused about who's who.
absolutely. So we might go on to the next slide. I'll pass it back to you, Marita.
So we're up to our 5th domain. Hopefully you've all remembered the 5 domains, so you're not surprised to see physical there. So again, whilst there are physical changes in those early stages, and we're learning more and more about those in terms of perhaps some physical changes that will even appear before the cognitive changes now. There's lots of research going on in this space. But generally, someone's still at home and they're still, physically able to do that. So I think we had a really interesting tip from a physiotherapist not long ago that, we all know that when we get our patients from the waiting room, we learn so much. Can they get up out of the chair themselves? Can they walk independently on their own? And then the next challenge is, can they walk and talk? So if you're talking to them and you notice there's a little bit of unsteadiness, that can be a bit of a clue that there is a little bit of work there to be done. So again, looking at how we can keep the person at home for as long as possible, that might be looking at putting in some physiotherapy or exercise physiology as well. And we know that keeping someone physically active is going to also maintain their cognition, their mood, and better sleep, which are all going to be much better for the person. Simple things. And I remember doing an elective with a old age psychiatrist, and every time he'd see a patient or have a student come in and see a patient, he'd make sure their glasses were off and their hearing aids were out, and try to really bring home that people need their vision and their hearing to optimize their cognition. So really important point to remember that people do need to make sure they're having their vision checked and that we're doing whatever we can in terms of hearing. The dentists also talk a lot about this, that it's really hard when you've got a patient in a residential aged care facility, and I've just had my mum move into a residential aged care facility, and dental work becomes so much harder. So keeping people's dentition whilst they're at home, you know, as good as possible, reminding people that they need to go to the dentist, you know, every 6 months to keep their dental health in good shape, because there's nothing worse than someone getting a dental abscess and they can't tell you that that's where that pain is coming from. And again, looking at optimizing all those cardiovascular risk factors, because they're going to give you more bang for buck in terms of brain health as well. And also, if they are on a high amount of medication, so more than 5 medications, thinking about getting your pharmacist to come in when that diagnosis is initially made, and they can help in terms of looking at how you might de-prescribe. So keeping people as physically active as possible is really, really important. I'm just going to quickly have a quick look if there's any questions there that we needed to answer before we go on.
There's a question from Laura just around the wait for assessment services is so long. By the time people get assistance, their needs have changed and increased. And yeah, that's sounding very tricky.
But it is a real problem, and really for someone with a diagnosis of dementia, when we think about our chronic disease management plans, 5 allied health sessions is not a lot to be able to help with that. So it's really looking at how you can get, I guess, best bang for buck. But I think even changing our lens from thinking that we have to wait for assessment in terms of thinking, well, what can we do? Who's around in the family? Who's around in our community who perhaps can give us a few ideas about how we can help just to get started is a good starting point. But none of this is easy, and yeah, we're certainly learning that we're going to have to upskill the whole allied health force, as well as GPs and practice nurses. We've got a fair way to go with that, but at least getting some understanding is a starting point. So if we move on to the next slide, that's how a management plan can look. So on the DTA website, the GP page, which will give you the resource for that, we do have some examples of GP management plans for the different stages. So, you know, if you're looking to try to develop a plan and get some ideas about who might be able to help you and what are some of the important issues to look at addressing, you might want to have a look at those. So if we go on to the next...
Before we do, Marita, just to comment that, again, a lot of this we do with other conditions, we're doing, you know, with other things. So rather than just referring and waiting for the memory clinic to make a final diagnosis, or, you know, perhaps waiting forever for, you know, assessment with my aged care or the equivalent in your area, is that we can actually see people regularly. We can get some of these things started. We can think about some of this, which actually gives them a bit of a structure to use as well, so that they don't feel quite so lost. And that becomes really important as well.
Yeah, and I think I was going to say also, a lot of these things that we're starting off with someone who we're making a diagnosis in dementia in early stage are really things we should be doing with all our elderly patients, because most of us do have some normal aging cognitive changes. So we're wanting to, you know, keep everyone's brains as robust as possible, or certainly someone with mild cognitive impairment as well. So if we move on to the next slide, I guess the other group that's really important when we're thinking about people living with dementia are the carers. And I don't know about you, but often when you talk to the spouse or the adult child who might be looking after a parent with dementia, often people don't even realize they're caring. You know, they're doing all this incredible amount of work. And I think it's something like 30 to 40% of carers are doing upwards of 60 hours of work unpaid per week, looking after people with dementia. It can be so demanding. You know, their needs can be such that that's the sort of care that they need. So remembering that the carers need caring as well. And if the carer isn't your patient, making sure they're checking in with their GP as well. So we know that up to a third do develop some depression because it is socially isolating. It can have a financial impact. So if you've had to be pulled out of your workplace where you can get a lot of where your finance comes from, where your social engagement might come from, where your sense of yourself might come from, that can have a huge impact. And physically, if you've got an elderly couple who are both in their late 70s or 80s, and one's taking over the care as well as often the running of the house, physically that can really be difficult for someone. We do know that the behavioural changes, because they can be really difficult to understand, and it can be challenging to figure out the best way how to manage those, do have an enormous impact. And from most of the research, it is usually the spouse who feels the most impact. If it's not a spouse, I'd say it's usually one of the daughters who's doing that. So there are supports there through the Carer Gateway and Dementia Australia. But I think just checking in on the person to make sure they're okay and what they're doing to look after themselves. And if we go into the next slide, there are some things again that we can do. Education, really important. I know when my dad had dementia, educating my mum about what it means and how best, not to argue with someone when they're telling you, something, because they don't have the cognitive capacity to understand. So we had to do a lot of work with my mum. Screening, so keeping my mum well, was really important, both mental and physical health. Looking at setting up, that the ability for respite, and trying to, a lot of people don't want to do that, don't want to go down that path, but it's about a stitch in time saves nine. So if you can keep the person caring for the person with dementia as well as possible, it will delay ultimate transition to RACF. And sometimes that is about giving them permission to use respite, and having sort of strategies to be able to manage some of the changed behaviours or cognitive concerns. And that can really come back to education, using Dementia Australia as that support service, or DSA if that's needed. We do know that there is some evidence that carers who can get access to CBT through mental health care plan, that can reduce the impact of care. It does delay transition into a residential aged care facility, and certainly will improve the resilience of the person caring. So there are other parts of the picture that we have to keep in mind. And so we're coming to the end now, but we're going to talk through who else can help and our resources. So I might hand back to you, Karen, so that you can go through those.
Sure. So if we just move on to the next slide. So again, there's lots of people that can help us, but again, as Marita has alluded to, for some of our allied health colleagues, they're also upskilling in dementia as well. But we certainly know that there's a lot of resources out there, and that we should be, both for ourselves, be able to find some support, but also for our patients that are living with dementia and their carers. And so it's really a matter of individualizing depending on what the person is actually needing. So not everybody would need everybody on this list, but there certainly may be some. I think probably out of all of those, a dentist, I know we did mention in that physical, it's really worthwhile in stage 1 looking at dental reviews. It's much trickier once we've got people in stage 3 in living in residential aged care who have got significant dental concerns, to get them sorted out. And that certainly can drive a lot of the changes in behaviour that we see if people have got dental pain and difficulties going on at that point. So definitely would recommend a dentist early on. But again, the rest depends on what our needs actually are. But pharmacy, again, for medication reviews, certainly useful. There's a question, why is chiropractor on the list? I guess when we're looking at some of the improving functions, that's not, again, depends what's in your area, I guess. For some of our people, that again, as an individualized thing, that may be useful, but certainly for some of the other things where we're looking at really enabling and changing functions, we've got a whole heap of other people we can use. And the challenge is, of course, as Marita said, if you're only using a GP management plan and you've got 5 visits, we really need to target who it is that we're actually using. If we're able to actually access more through My Aged Care or NDIS, then that might actually change who else we involve in somebody's care. If we move on to the next slide. So just to re-look it all again, so just thinking about ending as we started. So hopefully from tonight we've been able to show you that we are both able to look at diagnosing, but also initiating some of that management. Yes, there's some elements we can't do all on our own, like the, some of the medication, but in actual fact, that's only a tiny bit of management. And the rest of it, we're actually able to do all of it. And so certainly thinking about how we can use those stages and domains to help us plan our management is really useful. And that timely diagnosis significantly improves outcomes for people who are living with dementia and for their carers. And that although we can't cure dementia as yet, there's certainly a number of interventions that can improve quality of life. And as we talked about, some of that risk reduction as well. So I'll pass it back to you, Marita, for the final resources. If we just move on to the next page.
So this is the GP Dementia Resource Hub. So that's got links to various online courses that you can do if you want to. It has got the management plans and also a link to teaching plans that were developed for GPSA. It also has a link, which I think is on our next, if you go on to the next slide. It has a link to our podcast series, which we have not mentioned throughout the whole course of, I don't think the first webinar or this webinar, but we have got 2 seasons of a podcast called Dementia in Practice that has lots of really interesting interviews with people who are in the research world, the neuroscientists, the neuropsychologists, as well as people living with dementia. And as well, some of them are just us chatting about, the things that we've found challenging. So I'd encourage you all, if you like podcasts, to go along to wherever you download your podcast and have a listen to whichever one of those episodes you're interested in. And we do have season 3 coming out very soon. So thank you so much, everyone, for coming. I hope it has been helpful. It is just a starting point. We haven't got all the answers. The landscape of dementia is changing quite rapidly. You will have been hearing about, new medications coming out and new tests coming out. And we'll definitely be keeping people abreast of those, particularly through season 3 of our podcast series. But we just hope that this has helped you at least feel like you've got some of those frameworks to make a starting point when you're seeing patients in your practice that you think, may have some signs there. So I think we are going to hand back now, because I think Dr. Maguire is going to now talk us through how this might make sense on a more local level.
Just find where we're at. There we go. Share. Okay, so I'll briefly recap, if I can get this to work. Wonderful. What health pathways is for anyone who wasn't here last meeting. So basically, I see it as a one-stop shop. So instead of having thousands of different places I need to go, everything I need is actually on health pathways. So I've worked in WA, Queensland, New South Wales, and Victoria as a GP. And if this had been available then, it would have made my life so much easier every time we move states. So with this, it has a tree structure on the left that's searchable, or the search bar. On the home page, it has latest news as well as alerts from the department. Then there are pathway updates, so you can actually quickly see which are the latest pathways that have been reviewed, or new pathways. And then there are a whole list of resources right on the home page that you can use. And MPS medicine-wise actually still does exist. Just thought I'd let you know. Now, from each page, you can actually send feedback. So there's a feedback button there that you can send. Now, if you're not registered, please go, there's some options, go to the melbourne.healthpathways.org.au and hit register now. Or if you're watching, you can actually just use the QR code or send an email. So all of those options are available. When we look back at Anna, really what I'm wanting to do is just show Health Pathways how it can help in the initial management, in the ongoing management, looking at what your referral options are, and then resources. So this is the pathway. Now let me see if I can make this work. We did assessment last time. So we're now going to look at management. And basically you scroll down like that, you can see this. And when we look, we're looking at one, just bear with me, there we go. So we're looking at reversible causes and conditions. It's got all the information about, you know, when you think about referring, it has education and support. Again, it's looking at those preventative things, the lifestyle, the cardiovascular risk, the comorbidities. It's considering early, you know, BPSD and management of those symptoms. And then, as was already discussed, there is a delirium management plan that you can early on discuss with patients and actually put in place. So we've got one too. The other next area is certainly if you don't think they have dementia, we talk about with mild cognitive impairment, how to monitor and review. And again, one of the things was medications and the non-pharmacological sort of measures. So when we click on that, which you can do, we actually look at all the medications. So there's all the lists there. You can either click from the pathway itself or you can go back over to the tree. So this is the pathway on medications for dementia. There is again background, and then there's got segments on before prescribing, when you start treatment, and then review. And one of the big things we do need to do before considering starting management is ensure patients have had an ECG. So there are reasons why, you know, the cholinesterase inhibitors may not be appropriate in certain patient groups. Also, really good at the start to do weight and assess whether with side effects from drugs, people sort of can actually lose weight or, you know, feel nauseous. Then we start treatment. And so, okay, we're going to start them on the donepezil. You can actually click and open that, and it will go through really clearly the dosing, hints about, you know, when to take it. Then before prescribing, we've actually got direct links to the AMH and the therapeutic guidelines. So you can actually access the most up-to-date, accurate information. We've also got information on Momentine and when it can be used. I think it's going to open up too. Yes. So it actually talks about the drug and its adverse events, contraindications, and again, resources before prescribing. The other thing that, you know, really important for us is that follow-up and the ongoing monitoring once they are on medication. So we'll go back to the main pathway. So we've started them on treatment. We've actually, there are further things, and that does include when we're looking at referrals for home services through an aged care assessment and My Aged Care. It is all the pre-planning, so advanced care planning, wills, powers of attorney, and medical treatment decision maker, and also whether patients can give consent. There was also discussion about reviewing all medications. We actually do have a de-prescribing pathway that is based on Tasmania's de-prescribing documents. We've got sort of links to, if you want to do a chronic disease management plan, links to all the different allied health referral options. And then also looking at some people with COVID, if they've recently had COVID, their cognition can actually, you know, be off as part of, you know, long and post-COVID. Then we look down to referral. And with referral, there is referral to Cadham's Clinic or a geriatrician. And our pathway is called non-acute geriatric referral. And it goes through sort of just hints about when you would think of referring at any time. There's also advice from Dementia Australia and Dementia Support Australia with links directly to them. So we're going to have a look at the referral page really briefly so you can see what it looks like, hopefully soon. Scroll, scroll, scroll. There we go. Oh, and the other thing, certainly if they're younger onset, so the specific clinics for patients with younger onset or quite atypical features. And the other, just before we go, this is about fitness to drive. As one of the other pathways that has recently been updated is the fitness to drive pathway. So that's something to have another look at. Just today, I had the conversation again. You have a diagnosis of dementia. We need to actually, report to Vic Roads so that we, because you can't have an unconditional license anymore. And that's a hard conversation to have. So we'll have a look at the non-acute geriatric referral. So this is the referral page. There's a C note at the top about anything that is new or important. Then there are all the public services listed. And that includes required information and assistance if required, and then advice to patients. When we look at the options, there are lots of different links out, so including clinical trials. So there's lots of trials that are ongoing. So it is important that if patients are interested, there are options for us to refer on. Then there is the CADMS clinic. So say you live in the eastern suburbs of Melbourne, which I do, and I want to refer to St Vincent's CADMS clinic. Each look exactly the same. They have a fax number or an email, they have the referral form, they have the inclusion and exclusion criteria for each clinic, and this is updated and accurate. So if there's ever any information you find in there that's not correct or changed, we really want to know so we can continue to keep this as an accurate. And then the last thing that's at the bottom is all the information. So there's stuff for health professionals, and I'm now going to add education at the top. And then there's resources for patients as well. And that does include Dementia Australia and Dementia Support Australia, as well as the recent patient resources that we will have a look at. So just go through here. And in multiple languages. Now, next slide. So this is a locally developed dementia directory, as well as a patient resource, patient and carer resource. And they are available in English, Italian, Greek, Vietnamese, and simplified Chinese. So they are on Health Pathways Melbourne. Just a brief reminder, these are all the older adult pathways. So a lot of the things that we were talking about, including falls, including deprescribing, including the health assessments, both for residential aged care and over 75, as well as medication reviews. So everything is here without you needing to go anywhere else. And here are the fitness to drive and OT assessment. And when you're discussing about fitness to drive, looking at the other things about parking permits or half-price taxis or other options within community transport that are locally relevant. The other thing when we talk about, no, there's no specific item number, but there are lots of item numbers that we can use. This has, and I've updated it, so from 1st of July, it contains all of the latest item numbers. It is up to date, it is searchable, and please use it. Now, this is the carrot. If after this, you'll be sent a survey, so please fill it in. It's only 5 questions. It's getting you to look at these 10 pathways, and you can win a $100 voucher. So it's a win-win situation. If there are any other questions, please let us know, and we will be sort of at any time, and please send feedback. So not just because of the survey, but because we want to hear to improve this and make it a really usable pathway for clinicians. I'm putting you back to stop sharing. There we go.
There's a question for you in the chat. Dr. McGuire, can you access therapeutic guidelines via health pathways without subscription? Can't in Brisbane?
No, you cannot access anything unless you work for a hospital system. So it is exactly the same as, but I mean, a lot of GPs do. And the option is, if you don't have that, some people have AMH, as again as a subscription. And the other is the clinical software and the MIMS sort of information. But no, we have tried. And despite all public services having free access, general practice is, we have to pay for every single thing. So
unless
definitely
you work for the college as a supervisor or an ECT visitor, then you will get access.
Yeah, so there are certain sort of positions, but no, I have access because I write health pathways, but that's, sorry.
I think we're passing back to you.
Wonderful. Thank you. Give me 1 second. I'll just share my screen. Now, thank you all for being part of today's session. It's been an absolute pleasure to have you all here tonight. I hope you've taken away some valuable insights, and I'd also like to extend a special thank you to our exceptional presenters for their fabulous work. For your accreditation, and so that we can further improve these education workshops, please take a moment to fill in the event survey. You can do so now by scanning the QR code on your screen. At the end of the session, this survey link will also appear on your screen. Your responses are greatly appreciated and highly valued. By participating in tonight's RACGP accredited activity, you will receive 1.5 hours in educational activities. Northwestern PHN will lodge those hours through the RACGP on your behalf. There will be a follow-up email that everyone will receive, which will include a copy of the presentations you have seen tonight, in addition to other relevant resources, including a link to the previous session if you have missed it. You will also receive your certificates within the next 4 weeks of this session from Northwestern Melbourne PHN. Thank you all for your time this evening and your attention. That is all from us, and I hope you have a wonderful evening. Thank you so much, everyone.
Thanks so much.
Thank you all. Good night.
That was great.
No worries. Bye.